Hello everybody, welcome to the RADGames case from Rostock, Germany. My name is Marc-André and I will present you a 55-year-old patient presenting with medial knee pain of the right knee joint. Well, our orthopedic surgeons suspected right medial meniscus lesion and cartilage damage, and therefore they asked for radiographs. We performed radiographs of the right knee joint to rule out severe osteoarthritis or fracture. Let's have a look at the radiographs. You see here the radiographs in the anterior, posterior, and lateral view, and also a patellar view. And I will start with a task for you. So what is your interpretation of the radiographs? Is there a fracture? Are there degenerative changes? Is there a severe osteoarthritis? Or do we have a CPD disease? So I do not see any fracture. I do not see significant degenerative changes. But still the patient has pain. So we performed an MRI examination. And what you see here is a sagittal T1 weighted sequence. You see here the outer meniscus, so nice. You see here the bone marrow, the cruciate ligaments. You see the patellar tendon, quadriceps tendon, retropatellar cartilage. And then we come to the medial femoral condyle and the medial plateau. Have a look at the medial meniscus. So, do you see something? Please indicate the area of the pathology. And you see that you have decrease in signal intensity of the fatty bone marrow in the medial femoral condyle. Let's have a closer look to this in the proton density fat saturated sequence. Again, you see the nicer outer meniscus, you see nicer cartilage layers, you see the cruciate ligaments intact, but then we come to the medial femoral condyle. We see here a bone marrow edema-like signal. But do we see more than only bone marrow edema-like signal? And what about the tibial plateau? And the task is, which anatomic compartment is responsible for the medial knee pain? And obviously it's a medial femoral condyle because there we see much bone marrow edema-like signal. You can also nicely see the extent of bone marrow edema-like signal in the coronal sequence. You also see that around the medial collateral ligament we have some soft tissue edema. We also have edema overpassing the intracondylar notch. But do you see more than just bone marrow edema? So my task here is, please annotate if you see a fracture line. Here you see a tiny fracture line that is parallel to the subchondral bone plate. Have a look at the sagittal T1 weighted fat suppressed sequence after contrast agent administration. And let's go closer to the medial femoral condyle. You see again the bone marrow edema signal because that takes up contrast material, but also you see now the fracture line. And what is your diagnosis here? Is it osteochondrosis dissecans? Is it an osteonecrosis? Do we have a subchondral insufficiency fracture? Or do we have a transient bone marrow edema syndrome? You've seen the fracture line, and the correct diagnosis is subchondral insufficiency fracture. Subchondral insufficiency fracture of the central medial femoral condyle with extensive bone marrow edema was the origin of pain in our patient, and there are no associated cartilage or major meniscal lesions and no articular surface collapse. What do you know about subchondral insufficiency fractures and which statements are correct? And you see here the answers, predominantly in younger individuals. Symptoms typically develop rather slowly and progressively, typically without adequate trauma due to repetitive physiological stress, especially knee lateral femoral condyle. And the correct answer is that subchondral insufficiency fractures typically appear without adequate trauma due to repetitive physiological stress. Which of the following statements is correct about subchondral insufficiency fractures? Can SIF and osteonecrosis be used interchangeably? The subchondral fluid-filled cleft and articular surface collapse indicate lesions with unfavorable prognosis. Subchondral insufficiency fractures and Albrecht's disease are two forms of osteonecrosis of the bone. Spontaneous osteonecrosis of the knee can reliably be differentiated from a subchondral insufficiency fracture. So which answers are correct? Well, a subchondral fluid-filled cleft and articular surface collapse indicate lesions with unfavorable prognosis is the correct answer. A subchondral insufficiency fracture is not an osteonecrosis. Typically, it appears without adequate trauma in older individuals with an acute onset in pain, but X-rays are always unremarkable. So therefore, we should do MRI in these cases to see the bone marrow edema, but also to see the subchondral fracture line. With MRI, we can assess the prognosis because either a subchondral insufficiency fracture may heal spontaneously, or it can progress to collapse of the subchondral bone plate and the cartilage layer. And please remember that clinical pictures previously described as Albrecht's disease or spontaneous osteonecrosis of the knee or spontaneous postoperative osteonecrosis of the knee are rather forms of subchondral insufficiency fractures, and they are not a primary osteonecrosis. And just have a look for the fracture line, because this helps you to differentiate simple subchondral insufficiency fractures that have a good prognosis from those complicated by osteonecrosis with an unfavorable prognosis. And just the extent of the fracture line and the extent of an, let's say, avascular area between the fracture line and the subchondral bone plate helps in taking a good prognosis assessment, because this is what the patient and the clinical partners want to know from us. And for further reading, I can recommend you an article published last year in ROFO. And well, with this, I thank you very much. I hope the lessons learned from this case are clear. Now you know everything you should need about subchondral insufficiency fractures. And I wish you good luck with the RADGames and hope to see you soon at one of the next ESSR annual meetings. Goodbye.